for around and make a living out of this medicine. But there's an extra thing that we can get in the same profession compared to your colleague who is a Christian, a Hindu, an atheist. And what is that? That is what should guide me and you when you see a patient tomorrow. As I said, there's something more than a medical board on top of your head who will look at what you do, how you judge. You can write false notes, wrong vitals, and give wrong medications. The medical board, you can get away with it. But what about your Lord, who took you through medical school? And which conference can tell you that apart from Kammp? Number two, we can get much more ajr being medics. We can see all what is happening in Gaza. But look at the attention of healthcare workers. They're not just staying in Gaza, but they're offering a service that no one else can do. And that is our role in the society, apart from, yes, making a living. Apart from making a consultation fee, there's a lot of reward that God can give us if you first have the intention. Something I'm gaining much more from the hospital, from the patient, that no one can give you. And you're accountable for that. And you'll be rewarded more than other people. But we have to make it happen. You have to think about it. And that's where we need Kammp. Kammp is not just an association. I didn't know much about Kammp before I joined, but I appreciate I had an opportunity to join. There are a lot of things going around, a lot of need of more hands in the community. Medical professionals, all are needed, and that can be discussed. Some of those things can be discussed in such a conference and many more. So please take your time. We need much more of you in the conference and out of the conference. Please, it's an opportunity. Today I met a doctor from Kitui in the morning. I didn't know there was a Kammp member in Kitui. So how many other Kammp members in other cities? We need to know. We may have someone over there who needs of a medical attention, and if you have a brother or sister, you're safe at heart knowing that they'll get the best medical service at that particular place. This is an opportunity to network, to learn, and lastly, to prepare for your akhirah. In this conference, we have a session of a dying Muslim patient. What do you do with them? We were having a Muslim patient who asked to be in wudu when there is ICU. She agreed, I'm going to die, but let me die in dignity. And that dignity is different if you're Muslim and a non-Muslim. We asked for a Muslim nurse to be with that lady. We asked for a Muslim person to be with that lady because the nurses reminded her of adhkar, istighfar, tahleel, and tashheed. How many are blessed to have that death? But where can you get that apart from Kammp? It's only me and you can come together, and you tell me what can be done, and I tell you what can be done, and we join hands to make our professionals better, pure Islamically, and our patients to be much safer. With all that, I welcome you all again in this conference. Please feel free, should there be any critics, suggestions on how we can improve this conference, and afterwards, please reach out to any of my colleagues, the officials. We welcome you all again. Inshallah, you have a nice scientific conference. Thank you very much.
So session 1 will be moderated by Dr. Amir Faraj.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله وبعد. شكرا Bwana Chairman and the conference convener for letting me chair this first session. Alhamdulillah. We have several speakers. Without much ado, I want to introduce our first speaker. There'll be a little bit of a shift in our program. So our first speaker will be Dr. Mahmoud Abdulaziz Mahmoud. Dr. Mahmoud is our new consultant in town. He recently joined us, but not new anymore, almost 1 year now. He's a consultant physician also trained in pulmonology with master's degree in internal medicine and fellowship in pulmonology and tuberculosis from University of Alexandria, Egypt. He's also a member of Respiratory Society of Kenya, RISOC, Pan-African Thoracic Society and European Respiratory Society, ERS. He does interventional procedure in pulmonology with experience in bronchoscopy, medical thoracoscopy, ultrasound-guided procedure, and is also a certified critical care and sleep medicine specialist. Welcome, Doctor. So the topic of his discussion will be the role of intervention pulmonology in diagnosis and management of chest diseases. MashaAllah, tabarakallah.
Thank you very much, Dr. Faraj, for the good welcome. I want you to welcome all to our Kammp conference. Thank you very much. So this topic, the main intention was actually just to peruse the major interventional procedures. And you cannot summarize everything within 15 minutes, but we'll try and hit on the major issues. So as we know, interventional pulmonology is a minimal invasive procedure with the aim to diagnose and treat various respiratory diseases and malignancy. It's an advanced diagnostic and therapeutic procedure involving bronchoscopy and other pleural techniques which we are going to see, like ultrasound-guided and CT-guided procedures, with also medical thoracoscopy. Of course, it's a procedure-based subspecialty after pulmonology. Basically, it diagnoses lung cancer. You stage. With the diagnosis, we can take a biopsy. We can also treat by ablation techniques. And also there is palliation, which we can do, probably to secure the airway. We can do a balloon dilatation or even put a endobronchial. The hemoptysis. Also, in central airway obstruction, we have, for example, a patient with a lung mass obstructing the trachea. We can do some ablation. Mostly we have argon plasma coagulation, cryotherapy, either to freeze or even to use heat therapy to debulk the airway. So this, and then you can also put a stent just to secure the airway. We can also diagnose and treat chest infections like bacterial pneumonia, MTB, tracheal stenosis, especially patients post prolonged intubation, they tend to develop tracheal stenosis. So normally we do a balloon dilatation and put a stent. Lung nodules, of course, we have several causes of lung nodules. We have inflammatory, we have malignant lung nodules. So this basically bronchoscopy can help you to take a biopsy and diagnose. For example, if it's a malignant nodule or if it's because of sarcoidosis, this can give you a diagnosis and treat accordingly. We have interstitial lung diseases. We have several interstitial lung diseases, normally with a bronchoalveolar lavage, depending on the cells. Probably if it is lymphocytic or more of what we call monocytes, this also diagnosed and also doing a lung biopsy. So basically we have various patterns of interstitial lung diseases like idiopathic pulmonary fibrosis, non-specific interstitial pneumonia. So when you take your lung biopsy, when it is analyzed histologically, we can be able to diagnose which interstitial lung disease and be able to initiate the therapy accordingly. Of course, pleural-based procedures, pleurocentesis, pleural infections, pneumothorax, pleural masses. So nowadays we use ultrasound-guided, pigtail insertion, chest tube insertion, drainage. We can also do a pleural biopsy. In terms of pneumothorax, you can also, after inserting the chest tube, if it's a recurrent cause, we can even do pleurodesis. So lung collapse is also an indication for bronchoscopy. For example, there might be an endobronchial mass causing the collapse, or a mucus plug, or even an infective cause. Removal of foreign body, we all know foreign body in the bronchi or even in the lower lobes is common. So we normally use the rigid bronchoscopy, and we have the forceps to remove the foreign body. So these are the tools that we use: flexible and rigid bronchoscopy. Of course, we use the heat and cold therapy to either tumor debulk or even to try and achieve hemostasis, either through argon plasma coagulation, electrocautery, cryotherapy, or laser. We have also navigational bronchoscopy. Of course, we don't have this modality. Basically, it's a GPS of the bronchoscopy. This tends to use a computer system whereby you can locate a lung nodule or a swelling or a mass whereby the bronchoscopy cannot reach. So it's simply a GPS of the various lung segments. We have another modality called endobronchial ultrasound. Of course, it's not available in our country, but it's good to know that it helps us to guide in terms of taking lymph node biopsy and doing a lung cancer staging. Endobronchial valves is also very good in terms of what we call bronchoscopically lung volume reduction. Patients who with COPD, with significant emphysema, we can put what we call a valve, and it can occlude that area. So it's a one-way valve, meaning when the patient breathes in, there's no air going in, but there's air coming out. And of course, medical thoracoscopy, which we will see, it's a pleural-based procedure, which has significant help. Of course, ultrasound and CT-guided pleural procedures. Of course, bronchoscopy, you have rigid and flexible. This is the rigid bronchoscopy. It's a hollow metallic going to the airway. Basically, you use it as part of an intubation, okay? And mostly we use it in significant hemoptysis or removal of foreign body, or if we want to take large chunk of biopsies. The advantage of rigid, we have a large working channel. So this helps us in terms of putting our instruments, and also the same rigid is used as part of the airway management and ventilation of the patient. So we have ventilation, either what we call jet ventilation or closed system ventilation. These are the indications which we have discussed. This is the flexible fiber optic bronchoscopy. Basically, it helps us to navigate all the segments of the lobe, which the rigid cannot do. So you can go deeper segments in the right upper lobe. It can go even subsegments and even take biopsy and do a bronchoalveolar lavage. So its advantage is that we can use it just with sedation. With rigid, you need a general anesthesia. Of course, it has several advantages in terms of maneuverability, and also it has less complications. These are the images. As you can see, the vocal cord, normally we visualize the movement of the vocal cord bilaterally, any swelling, any inflammation. And this is the trachea. As you can see, the tracheal rings anterior and the posterior wall having the muscles. With the carina, the right is this side and the left is that side. So it's good for visualization of the airway. And these are the advantages of rigid vis-a-vis the flexible, and we have discussed it. Indications, we have said patients with endobronchial symptoms, chronic cough, not unexplained, hemoptysis, localized wheezing. Patient might have localized wheezing because of a foreign body or even a mass on the specific segment of the lungs, atelectasis or obstructive pneumonia. Evaluation of symptomatic patients with normal X-ray, This enhances in terms of diagnostic to see what is going on. Fiber optic in ICU, this is used mostly, patients can be treated for example, a ventilator-associated pneumonia. The patients are not getting well. We can do a bronchoalveolar lavage and do targeted antibiotic therapy. Sometimes the patients develop mucus plugs which occlude and cause lung collapse and cause high pressures, what we call autopip. So we can use the fiber optic to diagnose and even remove the mucus plugs and any infection that has caused the complication. Of course, before any bronchoscopic procedure, we recommend doing a CT scan. The CT scan basically guides us where to go. For example, if the lesion is in the lingula, so if we see it in the CT scan and we know the pathology is in the lingula, so the bronchoscopist is guided by the CT scan. This is what we can do. We can do a bronchial washing. You can do a bronchoalveolar lavage. So a bronchial washing is basically in the main airways, just putting saline and aspirating. But a bronchoalveolar lavage is a segmental. You choose a lobe and a segment, and you actually wedge and collect only in that specific area. We can do what we call cytology brush, protected specimen brush, and also bronchoscopic lung biopsy. We said we can diagnose a non-resolving pneumonia with bronchoscopy, or recurrent pneumonia at the same site, pneumonia in immunocompromised patients. Especially we have various fungal pneumonia in immunocompromised, ventilator-associated pneumonia. Okay. So basically bacterial infections, the bronchoscopy can be able to diagnose. Mycobacterial infections like TB, of course, we have seen several patients have TB symptoms. You do a repeated gene expert, the patient is, the gene expert is negative. But when you go to the right upper lobe where there is the consolidation, and when you take your lavage, you find the gene expert to be positive, or even the smear. So this helps us. Maybe if you have high index of suspicion, the patient has TB, despite the negative gene expert, we have the modality of bronchoscopy to also go further, and the sensitivity is increased. As you can see, we can also diagnose mycotic infections. We have seen several cases of aspergillosis and a few of coccidomycosis. Mostly the other ones are usually in America, Arizona. So here we don't have much, is mostly aspergillosis. And you can see we have diagnosed several. We do a bronchoalveolar lavage, galactomannan aspergillus, and once it's positive, we start therapy. Of course, lung abscess, sometimes patients have been started on perical antibiotics and they are not improving. They have lung abscess. We go in, you get probably it's a methicillin-resistant Staph aureus, and you start accordingly according to the culture. So your bronchoscopy will help you to get a lavage and even do a lung biopsy. Probably the lung abscess is due to PTB while you're giving your antibiotics. So that is also of help. Of course, mediastinal and hilar lymphadenopathy, you might have hilar lymphadenopathy because it might be TB or maybe lymphoma. So we don't know probably what is it. So we can do what we call a transbronchial lymph node aspirate and be able to diagnose. We have seen patients who are being managed as TB and yet they had cancer, lymphoma. So it's good to do what we call a TBNA to diagnose. Of course, the EBUS is the best in terms of guiding you which lymph nodes. But normally, with our setup, we use the CT scan to guide us to take the lymph node biopsy. Okay. So this is the diagnostic, what we have seen. This is the aspergillosis we have seen. Okay. And you can remove them. It's actually therapeutic. You can use your forceps to remove. And this is the bronchogenic carcinoma we can diagnose. You can see the airway is markedly occluded. We have pleural-based procedures. We have talked about transthoracic needle aspiration and biopsy. So you can use the ultrasound or the CT to diagnose and take pleural biopsies. As you can see, significant pleural thickening, and patients might have mesothelioma or even benign mesothelial hyperplasia. Of course, we have this modality, especially for pleural-based. So the medical thoracoscopy is done by the pulmonologist, and the VATS is done by the surgeons. So what we can do in the medical thoracoscopy, mostly we can deloculate, okay, remove the locules. We can do a pleurodesis. We can take pleural biopsies and even do mechanical or chemical pleurodesis. As you can see, the diagnostic pleural effusion of unknown origin, suspected tuberculous effusion, suspected malignancy, or even evaluate chest trauma. So the therapy that we can do, pleurodesis, lysis of the fibrous adhesions, and even pleural toileting. As you can see the malignancy, nodular masses in the pleura, which we can take biopsies, okay? This is the tuberculous empyema, as you can see. This is the pleuroscopy, also called medical thoracoscopy. This is the semi-rigid, and the other one is the rigid. And thank you very much.
Thank you very much, Dr. Mahmoud, for that brief but well-detailed introduction and overview of intervention pulmonology. I think we'll keep our questions at the end of the session. We have our next speaker now, and she's Dr. Saumu Wayua. Dr. Saumu, she's a consultant pediatrician at the County Government of Mombasa. She has an interest in infectious diseases, especially TB and HIV. She's the chair of the National Programmatic Management of Drug-Resistant TB Committee of Experts, recently appointed as the head of medical specialists at the Department of Health in Mombasa County. So we welcome our sister, Dr. Saumu, for the presentation. Karibu sana.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Okay, while they are preparing for our presentation, sorry I did not emphasize on the topic of our discussion. She'll be talking to us about emphasis on primary prevention and reducing child mortality.
Welcome to today's presentation. My session will be focusing on primary prevention, especially in reducing childhood mortalities. So this is just a brief outline of my presentation. We'll look at just some sustainable goals and the mortality rates both globally and also nationally in Kenya, where we are, and what are some of the causes of under 5 mortality in children, and just briefly touching on primary prevention and what we can be able to do to be able to reduce this. So looking at the Sustainable Development Goals, so this is just an agenda that was adopted in 2015 as an call to action to actually end poverty and also protect the planet and ensure that all people enjoy peace and prosperity. So there are actually 17 Sustainable Development Goals. All of them are actually geared towards, the main goal is towards ending poverty and other deprivations, but also include strategies that improve health and education, reduce inequality, and also spur economic growth, as well as now tackling climate change and also looking at environmental preservation. So all these are actually embedded in the 17 goals. So focusing now on the children is that we look at Sustainable Development Goal 3, whereby it's actually to ensure healthy lives and promote the well-being for all at all the ages. So this one has got like a number of targets, especially like around 9 targets. 3.2 is the one that specifically touches on neonatal and child mortality. And the aim here is to end preventable deaths of newborn and children by the year 2030. So the target is to reduce these numbers all the way down for the neonates, all the way down to below 12 per 1,000 live births, and for the under 5 children to reduce it all the way down to 25 per 1,000 live births. So looking at the global mortality rates, approximately 5 million actually died before reaching their 5th birthday. That was in 2020. So these mortality rates have actually gone down by 14%. From 43 to 37 deaths per 1,000 live births. That was between 2015 to 2020. But we are still not yet achieved the target that has been set of 25. While for the neonatal mortality still went down from 19 to 17, that is per 1,000 live births, but still we are not yet closer to the target. These are global data. Now, looking at sub-Saharan Africa, that is where we are as a country, we're still reporting the highest under 5 mortalities all around the world at 74 deaths per 1,000 live births. And this is actually 14 times higher than the risk of children living in Europe and in Northern America. So this is just data from the UN, the SDG report 2020, when you're looking at actually the graph. So sub-Saharan Africa, this is where we are. We still have the highest mortality rates when it comes to the children, and this is the neonatal mortality rate. So we're still above 80, while the target is actually above 12. So while you look at other countries, especially in Europe and especially Australia and New Zealand, they have actually achieved and gone way below the actually set target. So globally, the world, this is where we stand at 17 per 1,000 deaths per 1,000 live births for the neonates, and at 37 for the under 5, total under 5 mortality rates. So sub-Saharan Africa, still we have a lot of work to do, especially looking at our very high rates. Now, this is Kenya, our recent data from the Kenya Demographic Health Survey. So when we look at us individually now as a country, this is where we are. Our under 5 mortality is at 41 per 1,000 live births. We've been having a downward trend, but then still we are not yet reaching the goal. And even when you look at the neonatal mortality rate, we are currently at 21 per 1,000 live births. This is still above the target that has actually been set. So we are still losing a lot of neonates also in our country. So what are some of these causes of mortality that we actually have? For the neonatal mortality, quite a number of studies have actually been done, and even looking at the data, over 40% of all of them is usually due to issues to do with preterm births, especially with its complications, and also what we call the intrapartum related complications, the birth asphyxia, and of course the other major contributor now is neonatal sepsis. As you can see here, preterm births and their complications, sepsis, meningitis. Other causes like congenital abnormalities actually also fall under this category, but the 3 major ones are actually the ones depicted above. While for the under 5 mortality, the major causes, like the top 5 causes, have actually remained more or less the same all throughout, especially in all the developing countries. So Pneumonia, still high on the list, followed by diarrheal diseases. Malaria is still there. Measles is our problem. We still have problem with measles also. HIV, AIDS, and of course perinatal infections also contribute a huge chunk to this under 5 mortality. Now all of these are actually, when you look at malnutrition, this can occur either isolated, but most of these diseases also occur on the background of malnutrition. So malnutrition rates also in our country still are very high, and they contribute significantly to our mortalities. So when we actually now look at prevention of diseases, this is where we need to focus. Our investments, our focus, our energies mainly need to go here, because in terms of health education, promotion, interventions for the entire population. So these are interventions that are geared towards the entire population, not just at one person. Secondary prevention, of course, including currently this one also being scaled up in some of screening programs, especially when you look at so many other infectious diseases and even the cancer programs. While now tertiary prevention, this now becomes the most expensive part, because now you have already diseases setting in, especially the chronic diseases that require expensive treatments and rehabilitation to reduce complications. But an area that we can easily tap into, we are looking at primary prevention. So this one mainly will focus at scale-up of high-impact interventions, as actually envisioned also in our Kenya Vision 2030. So some of the things that we can actually be able to do as healthcare professionals is ensure we have quality, focus, and optimal antenatal care. And I know for the gynecologists in the room right now, the WHO guidelines, it's not just 4 visits, it's actually up to 8 visits, right? If I read correctly. And then skill delivery, these are also things that will need to be scaled up, especially in our healthcare facilities, and also postnatal care. Vaccination and post-exposure prophylaxis, this is one of the areas that is really gaining a lot of attention, especially after the COVID pandemic now. So you look at the causes of the under 5 mortalities, pneumonia, malaria, measles, diarrhea. All of these are actually vaccine-preventable diseases. So we need to increase our vaccine coverage. Like, for example, now currently the Kenya vaccination coverage stands at 80%. And I know this data will actually change, because with the recent COVID pandemic, these numbers actually went down, because there was a lot of missed opportunities for these children. Other important things that we can actually tap into include adequate nutrition, including breastfeeding and healthy eating. So our current coverage for exclusive breastfeeding is only at 60%, while breast milk is something that is readily available, naturally available in all our mothers. So this is something that we need to also encourage. We all know the importance and the benefits of breast milk, so this is an important area that can actually be tapped into. And of course, healthy eating. In this, I don't know, the 21st century currently now, we are focused more on junk foods and television rather than healthy eating, good diet, like balanced diets and exercise. So those are some of the things that we really need to, especially even for our children and our communities. Wash services, that is water, sanitation, and hygiene. These are critical and even came out even in the recent pandemics. We all know the importance of good hygiene and also having these services. And then other important prevention aspects include education on dental hygiene and also oral health services. So moving forward, the whole goal is to have a healthy and productive community by securing the health and the well-being of our people. So as communities, as healthcare professionals, what is our role towards health promotion? So this is where we come in as health professionals. We need to empower our communities in terms of good health, in terms of health promotion, and also try to actually create awareness about health-seeking behaviors, about the modes of prevention that are actually there, that they can actually be available. And most of these services, like you look, especially when it comes to vaccination and all that, these are actually services that are offered for free, even in the healthcare system. So these are actually opportunities that we can easily tap into to ensure our communities benefit from all this. Lessons learned from the COVID-19 pandemic. I think we all know COVID really came with a harsh bang, and it really taught us a lot. And now moving forward, it's all about emergency preparedness and also about how to ensure that our health and the well-being of our people, especially when it comes to issues to do with healthy eating and immunity, because this is an area whereby it caught us unawares and it caught us unprepared and quite so many lives were actually lost because of this. And then as a country and even the entire world, they are moving towards the realization of universal healthcare by ensuring accessible and affordable healthcare services. Now it comes to us as the healthcare management now, for those who are in management. Now, how do we ensure accessible and affordable healthcare services while at the same time expanding access to basic primary healthcare services to all our people? So these are some of the conversations that are actually going on at management level to ensure that all people are able to access services, and especially the basic primary healthcare services. And thank you very much.
Thank you very much, Dr. Saumu, for that presentation. With deep sorrow and whatever is happening currently, I think we are losing a lot of Muslim children. We are all aware. And it might change the statistic. Unfortunately, such things never come in world statistics. And we pray for those who have died, Jannatul Firdaus al-A'la, for those who are sick, Shifa Ajil, and may Allah give them patience, and we continue praying for our brothers and sisters in Gaza. So our next speaker will be Professor Zahida Qureshi. We all know her, but for those who don't know her, she has taught most of us. She's a faculty member at the University of Nairobi in the Department of Obstetric and Gynecologist. She has been involved in many trials, both locally and international, on matters pertaining to prevention and treatment of postpartum hemorrhages. And he's very close to mothers, and most of his practice, most of her practice is in maternal and newborn health. She'll be talking to us about early detection and treatment of postpartum hemorrhage. Karibu, Prof.
Shukran. Assalamu alaikum wa rahmatullahi wa barakatuhu. I would like to thank the organizers of this conference for giving me the opportunity to make a presentation on this study. It's early detection and treatment of postpartum hemorrhage using the World Health Organization MOTIVE First Response Bundle. This was a cluster randomized trial. This is to do with my study. I'll talk about it just now. So this was a study sponsored by the University of Birmingham, funded by the Bill and Melinda Gates Foundation. We've had a lot of discussion, mention of prevention by Dr. Saumu, and I'll talk a little bit about that, but we're going to talk about the trial first. So why did we feel it necessary to do this trial? How did we do it? And then any questions you may have, you'll be able to answer. So we have a few gynecologists in this audience, but we all have families. We all have women within our families who have babies. So you all know what happens when a woman goes to deliver. There is some amount of bleeding, but what are we talking about here? We're talking of excessive bleeding, how to prevent it, how to recognize it, and how to treat it if it happens. So globally, we have about 24 million women who actually suffer from postpartum hemorrhage every year. Most of them are at vaginal deliveries because those are the most of the deliveries globally. But sadly, about 75,000 of these will die from complications of postpartum hemorrhage. So why are things not getting better? We've been doing a lot of research on postpartum hemorrhage. We've been putting it in a lot of interventions, but yet we continue to have postpartum hemorrhage. So this is bleeding after delivery. Some amount of bleeding has to happen, which is less than 500 ml. So it's beyond 500 ml, that is postpartum hemorrhage. And if it is more than 1,000, that's severe postpartum hemorrhage. So those are the ones that lead to complications. So coming nearer to home, We have had the confidential inquiries into maternal deaths, looking at what causes the maternal deaths in this country. Our initial estimates were that we have a maternal mortality ratio of 362 per 100,000 live births. 2 weeks ago, we were in a meeting and the Ministry of Health told us it's much less, so we are happy. But as Dr. Saumu was talking about, you know, the SDGs and the targets that we have, we are supposed to come down to 70 maternal deaths per 100,000 live births, and we are way beyond that. So this has been the leading cause of maternal deaths in our country, contributing to about 38 to 40%, followed by hypertensive disease. So we have a big problem of postpartum hemorrhage in our country. So what is the issue? Why are we not able to tackle? It's because we take long in diagnosing postpartum hemorrhage, because we look and say, oh, this is so much blood loss. And when we delay coming up with a recognition of the amount of blood loss, then we delay our treatment, and then that further leads to a delay in treatment of refractory postpartum hemorrhage, which is you've done everything you could with your first aid measures, you've done your medications, and she's still bleeding. So this is an exercise we use when we do our trainings, and those of you who are sitting maybe nearby, I'll ask you. So we do simulations, and we have all those gauze and liquids to simulate blood. So if you look at C, this is a medium-sized kidney dish. What do you think the liquid there, if it were to be blood, what amount would it be? Maybe those of you who are sitting on that table right in front, I know this is postpartum hemorrhage, but every surgeon knows about blood loss and measurement of blood loss, right? Okay. So we have a water bottle. I don't know how much this one is, but the usual one is 500. So what does that look like? The one on C, this one here. A guess, 500, 300, 400? Okay. So look at what happens when we ask people to tell us what is the blood loss in ABCD. You can have anything for C from 1,000 to 300, and it was 300. So yes, you see, when you look visually, it's very inaccurate, okay? So this is a study that was done in 4 countries, Nigeria, Kenya, Tanzania, South Africa. It was a cluster randomized trial. So the cluster was a facility having between 1,000 to 5,000 deliveries a year. And the facility should have been able to provide comprehensive obstetric care, whereby they would be able to do a surgery for a patient with complications of postpartum hemorrhage. And the unit of analysis was a woman giving birth vaginally. So this was only for vaginal deliveries. So it had many sub-studies within the larger study. But the main study had initially 80 healthcare facilities who collected data over a 7-month period. Then half were randomized to go into the control, and half were the intervention site with a 2-month training, as we see here. And then they collected data for another 7 months. So the ones that were in the intervention, I'll tell you what those were, and the ones that were in the control is what currently we practice as the Ministry of Health guidelines. So our methods, so I said all women giving birth vaginally in these facilities. Our intervention was early detection by using a drape. Doctor, those of you who were wondering what this is a plastic drape that we put under the buttocks of the patient. And when she delivers, then we roll it out immediately after the baby is born. So all blood after that goes into this pouch here, and there are some markings at the bottom. So this drape is kept there for 1 whole hour. And we measure, you can actually gauge how much blood loss is happening, so that you can have a subjective measurement of your blood loss. Then at the end of the 1 hour, we actually remove the drape, and for the study purposes, we were weighing it. It becomes a very clean delivery because everything is going in and it's not spilling all over. So this is what we are advocating, and this is what we used. So when you recognize that postpartum is happening or almost, reaching those limits, then you have that early detection, and then you kick in your bundle, which is the massaging of the uterus, your oxytocic drugs, which is the syntocinon and others, tranexamic acid. Of course, you'll start with your IV fluids, and you'll examine in case you have tears. And your comparator is the usual care. Actually, all the elements are within the usual care, but they are spread out over a longer period of time. And our outcome was, the primary outcome was composite outcome of severe postpartum hemorrhage of more than 1,000 mLs of blood loss, or postpartum laparotomy for bleeding, or postpartum maternal death from bleeding. So it was a composite outcome. So what happens right now? Current practice is we diagnose postpartum hemorrhage visually, which may be very inaccurate, very delayed, and then we say, oh, I think postpartum hemorrhage is happening. By the time it may already be 1,000 mLs and we think it's only 500. So we start our intervention, we do one thing, we wait for it to work, we do another thing, we wait for it to work, and it takes a long time. And then finally, if it hasn't worked, we escalate. And then if all that hasn't worked, then we go in and hit our treatment for refractory PPH. So what are we advocating now, and what did we do in this trial? So we put in this drape, as you see here, under the patient's buttocks. We measured this blood. We could see what was happening. So that's the early and accurate diagnosis, the first E in this E motive. And then we start our bundle as soon as we recognize. So there are markings here. There's first one at 300 mLs, and the next one, the red one, is at 500. So if a woman is anemic, we talked a lot about prevention. We talked a lot about diet, Dr. Saumu. So antenatal women are supposed to have good diet so that they don't have anemia. We should prevent anemia. We should diagnose it, treat it if we need to, so that by the time she's delivering, she's not anemic, so that she has less chances of becoming hemodynamically unstable. So if you have an anemic mother and you reach 300, you know she's going to reach 500 very quickly, you can kick in your bundle very quickly. And definitely when she reaches the 500 line. So your bundled approach is all these things listed here, but very quickly. Within 15 minutes, you should have done all these. You put up your IV lines, you've given your oxytocin, your massaging of the uterus, you may even put in a catheter. You give tranexamic acid. This is supposed to be given slowly over 10 minutes. You examine the genitalia for tears, and if all that is done and it's not stopping the bleeding, you then rapidly escalate to whatever you'll need to do, to theater or examination under anesthesia. So, as I said, our primary outcome was a composite of the three. We, in our study, were actually putting this drape in for 1 hour or 2 if she continued to bleed. At the end of that, we would remove the drape, roll it up, put it on a weighing scale as you get in a supermarket, and then you can see you could read off. So study purposes, we took a photo of this and uploaded it for confirmation that that was the blood loss. So let us look at what we did in this country. We had initially 19 sites. Some of them were what we call the adaptive cycle sites. There were these yellow ones. Then we had 16 later. We had to unfortunately drop 2 sites, Maragua and JM Kariuki, for logistic purposes. And then we had 14 left. Half of them went into the control and half of them went into the intervention. And just by chance, we had all the Malindim, Samweni, and Roy, all the ones that around here who actually went into the intervention. So they had the training and then they continued to collect the data. So what did we achieve? We actually set out to achieve a reduction of 25%, which was from 4 to 3% of severe postpartum hemorrhage. And look at what we achieved. We have been jumping all over the place after we got the 60% reduction, literally. So from 4.3 in the usual care to 1.6 in the bundled approach. So this was phenomenal. I mean, we didn't expect it. So that's why we are jumping all over the place with these results. We had a lot of secondary outcomes, and as you see, we did have a significant blood loss of even, okay, it won't show there because of the postpartum hemorrhage more than 500 mLs also. You can see 8.5 versus 16. We're not going to go into those statistics. So this is what we achieved. And you can see here that the red is the usual care. Even after the training, post-randomization, you can see they are much higher than the intervention ones. How did we do all this? It was complex, very complex. 5 minutes, okay. So we had supplied all the intervention facilities with trolleys, as you see there, with all the equipment and supplies needed. Carry cases are small, cases with maybe just for 1 or 2 cases if they didn't have a large, labor ward. And then we had a lot of training, as you see, trainings going on using mannequins. We identified champions within the facilities who would make sure they would continue to train, staff, because staff movements are very common. And we had audit and feedback. So every month We would get an audit of that facility to see what had happened, how many deliveries, how many postpartum hemorrhages, how many severe, how many of them actually had the bundle, did they have blood transfusion. So every month, people would be looking forward to this and saying, okay, we did very well, we missed out a few, what can we do following this? So lessons learned and messages. We had a lot of shortages in the facilities. So those who are in public health, those at ministry level, every other day you have this thing missing and that thing missing. Right now, many of our facilities even have no IV fluids. You're asking the patient to go and buy even for a normal delivery. What happens if she has a postpartum hemorrhage? So there are a lot of issues. We also had an analysis of medications within this trial. We tested out brands of oxytocin and tranexamic acid, and we have poor quality medications. But those poor quality medications, unfortunately, have not been withdrawn from our system, so they continue to use them. So that is something we really need to work on. Healthcare practitioners, we have felt that visual inspection is not adequate. It's very, very inaccurate. So we need to make sure that we move to objective measurement. We are figuring out how to have these drapes rolled out all over the country, and we need to have and this can be done by midwives so that the doctors are even able to take care of other things. Policy makers, we need to move to making sure that we reduce postpartum hemorrhage, preventing from the diagnosis of anemia, preventing postpartum hemorrhage by active management of third stage, having good quality drugs, and if postpartum hemorrhage happens, by this recognition, then early treatment with a bundle. So Malindi Hospital, when the trial was getting over, they said, oh gosh, we're so used to using this, how will we manage without a drape? So they decided to take a Macintosh and come up and have a drape created. And at the bottom, there, they put the dish, which is, the bowl at the bottom, which is in a delivery bed, and put markings on it. So they actually became very innovative. And the University of Birmingham said, Malindi is the innovative hub for Kenya. So they were very impressed. We published in the New England Journal of Medicine on the 9th of May. And this was a global, thank you very much. And the same day, the results were released in a major conference in South Africa. We had a conference in Figo. This is the international conference. So on the right is Professor Hadiza Galadansi. She was the PI from Nigeria. In the middle there is Dr. Fadloon Al-Baithi. She was the PI from Tanzania, and myself. Our South Africa colleagues could not join us for this conference. So the Kenyan hub, my co-PIs, my study team, data managers, admin, midwives, and up there is Professor Ari Kumar Sami. He was the lead at University of Birmingham. I would like to thank all those, and I have a lot of materials to share for those of you who might be interested. This publication, and the publication on the poor quality medications. And very luckily, the Bill and Melinda Gates Foundation actually decided, because we had such an impressive result, they will roll out this intervention in all the sites, 19 in this country, all the 80 facilities for the 4 countries. For 1 year, they have supplied us with the drapes for all those facilities. So they are very interested in further following up and making sure that it gets rolled out. We are having consultations with the Ministry of Health. But we have very enterprising people in this country. There is somebody who has actually started even manufacturing this. He's even almost patenting it and importing machines. And anybody interested, I will even share what he has come up with. Environmentally, we also need to be aware. So we are trying to see if the top part can be reusable, clean, and the lower part is what can be disposed. So we have a lot of things happening. So we are very excited, and we are hoping that eventually we will have a reduction in maternal morbidity and mortality, and our goals can be met, hopefully, if not at least nearer. So thank you very much for giving me this opportunity. Jazakallah.
Thank you very much, Prof. Jazakallah khair. MashaAllah, what a wonderful study. And this is a challenge to the upcoming doctors, consultants, junior specialists. to be involved in studies, and we do more of this presentation in such conferences. So I think we've been, if you've been watchful and following up so carefully, most of our presentations have been on prevention, prevention, and prevention, which is key, especially in our life and in medical practice. And as we all aware that prevention is better than cure. Al-wiqaya khayru min al-ilaj. So our next speaker, without wasting any more time, I think the IT guys can start preparing for her presentation, will be Madam Mwanasiti Mikidadi Abdullah. She is a public health officer based at Coast General Teaching and Referral Hospital. So karibu sana.
Continue, it's the same, right?
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Okay. I'm called Mwanasiti Abdallah. I'll be taking you through infection prevention and control. Still prevention. Okay, the introduction of the infection prevention control. Yes, these are the sets of practices and protocols and procedures that are put in place to prevent transmission of infection that are associated with healthcare settings. Okay, most of these okay, a set of practices, protocols, and procedures that are put in place to prevent transmission of infections that are associated with the healthcare settings. Okay, in our healthcare settings, we have a number of infections. So we have health-associated infections that the patients developed during the course of receiving healthcare, treatment for other conditions, and occupational health infections. These are acquired by healthcare workers as we give cares to our patients. Okay, the effective infection prevention control is fundamental in provision of quality and safe care to patients. So as we give care to our patient, we are supposed to take note of infection prevention control. Okay, maintaining a safe working environment for healthcare workers. So we are also in danger as we give health care to our patients. We can also get occupational infection. Okay, this is the chain of infection. Okay, the chain infection, this is the way infection are transmitted. Therefore, the infection prevention control is to break a link in that chain to prevent the transfer of the pathogen. Okay, this is the chain of infection. We have the infectious agent, we have the reservoir, we have the port of exit, means of transmission, port of entry, and susceptible host. Okay, in the infection agents, there are a number of infections. We have the pathogens, the bacteria, the viruses, the protozoa, and etc. Those are the infectious agents. The reservoirs. The reservoirs can be the people, the equipment, the water, and the surfaces. The port of exit, okay, through excretions, through secretions, through blood, urine, and fecal. The means of transmission, how? Okay, it can be through contact, it can be through airborne, it can be through vehicles, vectors. The port of entry of infections can be through the broken skins, respiratory, GI, mucous membrane. Okay, the susceptible host, most of the time these are the immunocompromised people. The age, the under 5, the elderly, the pregnant women, the lactating mothers, and the people with chronic conditions like TBs, diabetic. So how can we break this chain of infection? All this chain infection, how can we break the chain infection? We'll start with the pathogens. With the pathogens, okay, we'll give antimicrobial therapy depending on the condition the patient has, the disinfection, the sterilization where we are working. That is the infectious agent. The reservoir, the reservoir, okay, we can do the engineering controls. That is the environmental cleaning, disinfection, proper food and water storage. In the port of exit, we do hand hygiene. Hand hygiene is very mandatory as we give our care to our patients. We normally emphasize on hand hygiene so that we prevent infection. We prevent ourselves and our patient from getting health-acquired infection. Disposal of waste. As we do our daily health care, we produce waste. We are the waste producer. So as we produce those waste, we're supposed to manage our waste at the source. The mode of transmission. In the mode of transmission, also have hand hygiene. Hand hygiene is very mandatory. If you do hand hygiene, we'll prevent many infections. The environmental sanitation, where we are, we make sure that we are in clean setup so that we prevent any infection. Our equipment, we disinfect them, and also we sterilize, and also put on PPE, depending on the work we are doing. Port of entry. In the port of entry, as we hand hygiene also prevent infection. The aseptic techniques we are doing, the wound care and the catheter care, and the use of the PPE. The susceptible host, our susceptible hosts, we give them immunization or rather vaccination, the proper nutrition to our patients, recognize of high-risk patients, and also proper treatment for our patients. Okay, the infection prevention practices, there are a number of practices where we normally do them to prevent these infections. The practices used in the care, we have the standard precaution. These are the practices used in the care for all patients at all the time. These are the hand hygiene. Hand hygiene. the rational use of personal protective gears, the proper management of healthcare waste. As earlier said, we are the waste generator. As we give care, we produce waste, different categories of waste. So we're supposed to manage this waste accordingly. Injection safety. As we do the injection to our patient, we have cleaning and disinfection or sterilization. Environmental cleaning, our setup should be clean. We should disinfect our surfaces before we start our day. Reprocessing of medical equipment and linen management, and also respiratory hygiene etiquette. Okay, we start with the hand hygiene, the introduction. Okay, when to clean? The healthcare workers' hands are the main route of cross-transmission of potential harmful pathogens. That is self-explanatory. So when we take care of our patients, we ensure that our hands are clean. And scientists estimate that up to 80% of all healthcare-associated infections are transmitted by healthcare workers. So when we do the hand hygiene well, we'll be preventing this 80%. We want to lower the percentage, and it is us who will lower the percentage. The hand hygiene protects the patients against harmful pathogens carried on healthcare workers' hands. We normally think that we are very clean, so let's take care of our hands. The hand hygiene protects healthcare workers and the healthcare environment and harmful pathogens. Okay, the patient, where the patient is, the surroundings, or all the patient and the surrounding, they all have pathogens. So we're supposed to take care of the patient and ourselves. Adherence to recommended hand hygiene practices will promote patient safety and prevent infection. Okay, hand hygiene. When are we supposed to do the hand hygiene? We have the 5 moments of hand hygiene. 5 moments of hand hygiene. Before we touch a patient, before and after, we are supposed to hand hygiene. Kwa hivyo, wash hands when they are visibly dirty or visibly soiled with blood and other body fluids, or after using the toilet. So when they are visibly dirty, don't hand sanitize. Kindly wash your hands with soap and water. Okay, action of cleaning hands, either by using the soap and running water, commonly called hand washing, or alcoholic-based hand rub, referred to as hand sanitizing. Why? Okay, hands are the main pathways of germ transmission during healthcare. Hand hygiene is the most important measures to avoid the transmission of harm, germs, and prevent healthcare-associated infection. How? Clean your hands by rubbing them with alcoholic-based formulation, or wash your hands with soap and water when hands are visibly dirty or soiled. These are the 5 moments of hand hygiene. Number 1, before touching a patient, before clean aseptic procedure, after body fluid exposure risk, after touching a patient, after patient surrounding. These are the 5 moments of hand hygiene as we give our patient care. Okay, this is how we're supposed to do the hand rubbing, the procedures. We are told it takes only, for hand wash, 40 to 60 seconds, even less than a minute. For hand rub, 20 to 30 seconds as we do the hand rubbing, so there's no harm. Okay, the role of hand hygiene prevent transmission of infectious agent from one patient to another. Healthcare workers to patient and environment. It also reduces the healthcare-associated infections, prevent transfer of germs to inanimate objects and surfaces, prevent increase in antimicrobial resistance by reducing the number of patients infection to patient. Kwa hivyo, as we do the infection prevention, we'll be avoiding health-acquired infection. The PPE, kwa hivyo the PPE, as we do we take care of a patient, supposed to protect ourselves. We have the standard transmission, the standard and the transmission base. Kwa hivyo the PPE, okay, we are supposed to assume blood and body fluids of any patient could be infectious. That is true, and recommend PPE and other infection control practices to prevent transmission. Okay, the standard precaution for PPE, at any given time as you give the care to the patient, you're supposed to be in gloves, depending on the care you are giving, the gown, and the mask, the goggle, or face shield to prevent for any splash. Okay, rational use of PPE continuation, you have the transmission base, the contact precaution, we normally wear the gown and the gloves. The droplet, we wear the surgical mask, and the airborne, we wear the respirator. Healthcare waste management, the estimation is that, as earlier said, okay, the 85% of the waste generated, they are non-hazardous, that is general waste. It's only 15% that is infectious. So when we segregate waste well at the source of infection, we'll have very few infectious waste to manage. This is how we're supposed to have, where you are working, you're supposed to have the black, the yellow, and so on and so forth. And those are the safety boxes. These are the bad practices which we normally have in a clinical area, so let's note this. It's very rare we have good practices. Wherever I go, I do my inspection, I normally come across the bad practices, so kindly take note of that. The sharp waste, the right waste in the right bins, we are not supposed to recap, 3/4 rule, to be placed 6 inches. We are supposed to place our safety boxes 6 inches from the floor so that to avoid any liquids. Avoid procedures on the patient's beds. We are good on that. We do procedures on the patient bed and we forget to remove the injections, and they end up going to the laundry. And the laundryman there gets pricked by those injections. Do not collect syringes for later disposal. As you do, you are supposed to do not reuse or recap. Okay, when we do the waste management well, we'll be reducing the risk of infection, the risk of injury, create clean and safe workplaces in the healthcare facility, reduce waste-related odors and attraction of vermin, assure well-protected environment. Time up. Thank you.
Thank you very much, Sister, for that presentation. I think it's one of the most important presentation. And dini yetu yenyewe inatufundisha al-Islamu nadhif. So all these, if we can really follow our teachings, alhamdulillah, it will be a good way of preventing most of these infections. So last but not least, we have another speaker. This will be the last talk of our first session in this conference. The topic will be on research on Muslim by Muslims. Research on Muslims by Muslims. And we are privileged to have Dr. Saade Ahmed Abdullah. Let me introduce her briefly. She is one of our senior Muslim Kenyan public health professional with almost more than 20 years of clinical and public health experience in HIV, tuberculosis, and malaria. and she's been involved in strategic planning, grant writing. So if you have anything pertaining to writing, we have our experts with us, alhamdulillah, mashallah. Project management, monitoring and evaluation, and health informatives targeting host, displaced, keys, and vulnerable population. She has worked in several NGOs locally and internationally. Karibu sana, Daktari, and wish you a privilege.
Assalamu alaikum. Okay. It's a pleasure to be here. Our journey began sometime this year, early January. We were privileged to visit Professor Muhammad Bakari's library in Karen with Dr. Nabila, Dr. Fatma. And his 2,000 book library is very impressive. He has a section on Kenya, books on Kenya politics, democracy, radicalization, women empowerment. There's so much that's been written on Muslims with regards to those. And he also has a section on Islam and hygiene and health. But I could not find a book that linked about Kenyan Muslims and health. I've tried to Google a lot of times, and I just have not seen a comprehensive text that profiles our Kenyan population by health status. I've been trying to see, even in presentations, or asked even practitioners, how many of your patients are Muslims? What proportion of your patients have diabetes, have heart problems, have HIV? And unfortunately, they'll be like, we're not collecting that data. All right, where do I go? Okay. Wait, show me. I point where? Here. No, this one. All right, so okay. I hope so. So the 17th Sustainable Development Goal encourages countries to add ethnicity and race in addition to what you routinely collect as health workers in surveys. You routinely collect age, sex, location, and even wealth quintiles. But these other variables, I need to go to the US to be asked in a health facility, what's my race, what's my ethnicity? But in Kenya, for some reason, there's some hesitancy, all right? And what is ethnicity? It's actually a complex mix. It's cultural. There's diet. There's religion, ancestry. So we know here, some people say we have 50 tribes. Some people say we have 70. But they are distinctly emanating from like 3 different cultural origins, and that is, or ethno-cultural groupings, Bantus, Nilotics, and the Kushites, all right? And so the largest groups we know, it's the Kikuyus, the Luos, the Kambas. Those are from Bantus. We have the Kalenjins, Luos from the Nilotes. And we have the Somalis, Kushites, right? But when we try to say how many are Muslim, when I was young, we'd say 30%. But the census, official figures, the CIA, they say it's between 10 and 11, all right? So who are these Muslims? Where are they? What we see is, we have some, groups that are synonymously Muslim. When we say Somali, you know that that is more or less Muslim. If we say Swahili, are we all Muslim? The other tribes, it varies. Nubis, we presume it is. But, the numbers, there's a lot of politics of numbers. Hiya, how do I do this? Could someone be changing for me? Huh? All right. So anyway, the next is maps of, So these are maps that you go to Google. That one is from CIA 2015, and it shows the breakdown by ethnicity, okay? And basically, Somalis, they were said 2% at that time. The Mijikendas, 5%. But when we look at the 2019 census, The table or the chart below is from the 2019 census. And the bigger the box, the darker it is, means the larger the numbers. And it shows Somalis, they dominate as Muslims compared to the other tribes. Next biggest group is the Mijikendas. No. Thank you. It's the Mijikendas, and we have different groupings. But then the others, are we really just 186,000? The Nubis, really like 26,000. They have lobbied and said they are over 100,000. So there's a lot of politics of numbers. Next. When we look at by religion, someone on Twitter, X, drew the map by religion. So if we see like half the country looks Muslim, yet we're told we're 10%, you know? And then if we look at those census, what we thought were Muslim predominant regions, we see Mombasa is only 37%. Kilifi is only 17% Muslim. Do we agree with these numbers? Nairobi, is it true we are only 7% Muslim? I personally have reservations about that, okay? But we see Lamu, half. So there's a lot of issues that with the numbers. Next. Yeah, so for this mapping exercise, you know, we just embarked on a journey on a volunteer basis just to see how much research there is. Because let's gather the evidence on what has been done by Muslims and on Muslims, all right? And then take inventory, review the papers, look at what non-Muslims are studying with regards to us, all right? And then to describe the health situation, and hopefully these findings will lead to bigger things. But for this presentation, I'm focusing on the first two objectives. Next. Yeah, so how did we do it? We sent emails and through WhatsApp, requests to our networks. You know, if you have any publication on health and research related, please share, all right? But we got only about 50, all right? Then we also searched through PubMed, Google, whatever, all the search engines, some organizational websites from 1985 to 2023. And what did we look? We said, is it religion and health? Or is it Muslims and health? Or Kenya Islam and health? Or Somalis and health? Or Swahilis and health? You know, all kinds of mix of words to be able to find this, all right? And then we also went to university repositories. And so we said anything that's an abstract, a presentation, an article is eligible. And if we say a Muslim researcher, who's a Muslim researcher? Is it a name? We have the traditional so-called Islamic names. But is it that all Muslims go by that name? Are there Muslims who have non-Muslim names? Or there are names that I can't tell? Like if I tell you Gure Taro, what kind of name is that? Is that Muslim or not? You know? So it was challenging, but we said the standard classic Muslim names, at least one will accept. Next. All right, so we were two reviewers. It's tedious. And then we used an Excel tool to put all these variables. And then we documented yes or no, whether religion or ethnicity was covered, then cleaning and analysis. Okay, so I'm going to present to you the graphs and also tree maps, all right, by focal Muslim subject area and all that. Next. Yeah, so this is what we saw, all right? Then, so I looked at 911 between February and last month. And of these, we saw like 864 fit our criteria. And of these, 721 had at least one Muslim name. And then 143 had no Muslim name. Then of those 677 now, because there are some that have restricted access, you have to pay. And I don't have the money for that, yeah? Or you say you have to contact the author directly, I don't have the time. So, but we got many journal articles, dissertations, conferences, and then there were, majority were like first author, at least half were first author Muslim. Others were second, third, so it was a mix. All right, next. Yeah, so this is what we saw. Where did they come from? These are the sources. Majority is journal articles. And mashallah, Muslims, we are publishing wide. I learned that you have a journal for every part of the body, you know, that's named. We saw, like you can see, is it the fifth one is University of Nairobi repository. Next is KU repository. Then we had JQuat. These universities is where you get the master's and PhD thesis. Very good articles and documents. And that's where you get majority on religion and health. But the others, it's people, mashallah, publishing, but it's about health. All right, next. Yeah, so who and where are these people who are publishing? So of the Muslims, alhamdulillah, Almarhum Hassan Said, my classmate, Dr. Khadija's classmate, was the leading. He died more than 5 years ago, but today he's still the leading researcher, okay? And then Madam Qureshi, alhamdulillah, I was so excited she's here. She is the leading female researcher, Muslim, all right? Then we have Shaheen Said, our classmate also, our CC. I'm really hoping that she'll be here because we really need to appreciate her. We have Muhammad Karama, everyone knows him. Fatma Khalfan, she's here, right? There's Fatma Some, there's Rahma Udu. I don't know if you know them. Yeah, Rahma is at TUM, Fatma Some is in Eldoret, in teaching. We have Jamila Rajab, Halima Mwenesi, Muhammad Jalan. Those are like the leading, according to my search, all right? I could only find whatever I found. If there are those that I didn't cover in terms of leading, please let me know. So earliest manuscript was Asha R.J. Haji. I don't know where she is, but she talked about socioeconomic factors of khat. Very interesting, and abuse. So even though it's a source of income for some, they depend on khat to survive. And so what we are seeing is from 1985, productivity has increased over time, all right, till 2018, when Almarhum Hassan Said passed away, it declined. He was churning, like, mashallah, many, many, many journals. Even after death, there were still some that were in his name, all right? And then what we see is now the names. So you see him leading, then Madam Qureshi, then the others. And these are by the years. Next. I'm sorry, I'll take more. So you've done next. So these are leading with the Muslim lens. The others were leading just health, all right? But when you add that Islamic lens, we are looking at people who use drugs who are Muslims, sex workers who are Muslims, gender-based violence, Muslims, post-abortion care, Fatma Sood, is she here? She looked, thank you. She looked at Muslims, Mombasa, all right? So these are, we'll see that they are shared interests for non-Muslim, Orange, and Muslim, all right? But basically, we have a lot of studies on this. Next. Geographic coverage. We are looking at bulk is coast for religion and health. Many studies are focusing on the coast. Yet we are seeing the coast is diverse, 17% Muslim. Some are Kenya, but some are Nairobi. Northeastern is not as much focused, even though we know it's the most predominant area, all right? And which designs are we looking at? Cross-sectional is the most popular, all right? Then followed by qualitative, secondary data analysis. The trial that Professor Qureshi mentioned, we're not applying it to religion and health studies. Next. Yeah, so this is what we have in the poster. You can study behind. Next. So these are the 25 who used a Muslim lens, all right? Okay. The other is just health. And we had even Dr. Qureshi, 59 studies on maternal health, yeah? But here we're looking at those who had a component, Lubna, mental health, what are perceptions of Muslims with regards to mental health, seeking care. Muhsin Sharif, you're here. You said you were not sure whether I'd captured you. Yeah, all right, next. Then these are, we need to appreciate those who've published one paper, all right? Yeah, we have over 40 who are here I think Faiza, Said, Maalim, you know, that these are the papers I could find. So whatever I couldn't find, I couldn't report. But basically, we are rich. Next. Yeah, so conclusions is we have, mashallah, alhamdulillah, a large pool of Muslim researchers in Kenya, all right? And the professional you had, Bill and Melinda Gates Foundation, Johns Hopkins, WHO, they have these rich networks, all right? North, south, and all that. Now, we know that we're ethnically, racially, culturally diverse. So any study that we do, we have to consider that. So we need to agree, what's the definition of Muslim? Is it Muslim a name? Is it Muslim the practice? What is it? You know? Then what are our population size estimates? Any study we do, we need to understand what's our population base. Do we agree with those numbers? And then what about the Muslim professionals? You know, how ready are you to incorporate this Islam into your studies when you talk about infection prevention or postpartum hemorrhage or whatever? All right? Next. Yeah, so this is my dream. I don't know if it's a shared dream with Kammp or the rest of you of where to go with this. Because we don't have a committee on research or an agenda or roadmap, you know. How do we expand Kammp to do research with others and juniors? People want to do research, but they need mentors, all right? And then, as I said, I've just mapped, but I need to now go to the text to say what are the findings and put it in a book like this. This is a book that Professor Bakari did for education after a meeting. They put all the discussions into a book. I can do the same for what we found, but with other people's approval. Next. Yeah, so I would like to acknowledge all these, yeah, who made it possible for us to, you know, show and appreciate this work that they've done. I would not have been able to do it without them. And I think I'll stop there. My time is up. Thank you.
Thank you very much, Matt. Jazakallah khair, Jazakillah khair, mashallah, tabarakallah. I think we've come to the end of our first session, and it's a time for question and answer. I'm kindly requesting all the speakers, please, just come and have a seat at the podium here, while, at the stage, sorry, while, are there any questions? And maybe we can have someone with a speaker so that can assist to move around and we get questions. Yeah.
Another mic. Another mic.
Thank you so much for that. Wonderful presentations from all the speakers. I have a question for Dr. Saad, and I think very excellent last presentation there. Really caught my eye there. And I remember Prof. Hassan is one of the people who led me to the path that I took. So thanks for presenting that. So the question is relevance. So what exactly would be the relevance of research pertaining to Islam or Muslims? Is it the information from the data that's collected, or is it the author from the data that's being collected? And that relevance, how do you foresee that being applied to the wider professionals? Thank you.
Okay. Oh, I thought we were taking a pool of questions first, or?
Yeah, I think we can do that. We
Yeah?
can take
Okay.
just a pool of questions, then they can be answered.
Assalamu alaikum, and thank you so much for the presentations. My question is to Professor Qureshi. In terms of the study that was done, Again, there are many studies that have been done. I think, one also involved in saving mothers giving life, which is, again, a study that we did in reducing maternal and newborn deaths. Zambia, Uganda, and Nigeria. So, I mean, amongst the studies that have been done, also in terms of the use of the uterine balloon tamponade, we've used that, the anti-shock garments in terms of reduction of postpartum hemorrhage. So this is great that you all got 60% in terms of your results, but where do we go from here? Because again, these are not the first studies. These are not, I mean, as you discussed with WHO, the government and other governments as well, where do we proceed from here? That was my first question. And then I think the second question that I have, Dr. Saad, I think that was great in terms of looking at the research of Muslims. Thank you for inviting me into this particular conference, but also being a Muslim researcher, what do we do with this research? The one that I did was 2003, I think, to 2005. It's still relevant. What is the usefulness of that research that I've done? We're still having the same maternal morbidity and mortality, including infant deaths.
Thank you. Can you introduce yourself?
Dr. Fatma Sood.
Thank you.
Assalamu alaikum.
Introduction, please. You introduce yourself.
Okay, thank you very much. My name is Dr. Dabar Abdi from Garissa. Thank you very much for these wonderful, presentations. First of all, I would like to ask Professor Qureshi, I have seen from your map particular areas that you did your research, but you left the most important areas that actually majority of the mothers die because of PPH. In the northern Kenya, what was the reason for the exclusion? And is there any hope? Because I'm sure, I'm very happy Dr. Khadija is here. There's nobody who did better understanding the problem of some of the women after they created the maternity shelter. And the largest number of deaths we have the mothers in northeastern provinces because of PPH and also anemia. Is there any which can be done? Dr. Khadija, Dr. Saad, thank you very much. That was really wonderful.
We'll take one question.
Thank you. Assalamu alaikum. Unfortunately, people tend to ask more questions to the last speakers rather than the first speakers. So I'm going to ask each speaker to share with us, out of their presentation today, what is the suggestion, proposal, call to the Muslim medical professionals here to be able to make a difference in that particular area that you have made the presentation. But two specific questions. On research, I would really like to ask Kammp to consider setting up a journal and tied to that, have some clinics for writing. Because many times we think it is easy to write, writing is very difficult. And although we may have the information and the knowledge, but putting it out there so that peers can be able to read is difficult. So on research, my challenge to Kammp is, let's think of a journal. On Zaida's presentation, my question is, what's the cost of intervention, a successful intervention? What's the unit cost so that we see, rather than go to gates, we see how we can be able to actually make a difference here locally? Thank you. My name is Ahmed.
Yeah, assalamu alaikum wa rahmatullahi wa barakatuh. My name is Khadija Ahmed Abdullah. Thank you so much for the excellent presentations. I think mine, when we look at the data currently, and you go deep into the data, you will see, as some of my colleagues have said here, the Muslim communities generally in terms of geographical location, most of the mortalities, you tend to see them in those locations. Maternal mortality in this country, northeastern, we all know. Studies that have been done, simple things like hand hygiene. it is in these locations that you have the worst performance. You might see 0% in the cost, 0%. And hand hygiene, it means washing with water and soap, not just. So people question that we are Muslims, we always take wudu, but we don't use water and soap to do it. And that's what is known as being very effective. So for me, I see we have a role, and especially Kammp, I think, leading us to really look at how we do the basics. And the basics are hand hygiene, the basics are breastfeeding, the basics are vaccinations, and these cost very little. This is what we call low-cost, high-impact interventions. I know the focus here, we do talk of prevention, but when you look at the agenda, most of us are medics, so curative care, tertiary care is what we'll focus on, but I think we need to make that shift if we are to have an impact on our population to reduce the mortality that we're talking about. Really going back to the basics and talking about what really matters and what impacts that we will have on the outcome of children, women, men, and all of us together. Thank you.
We can take the last question.
Assalamu alaikum. My name is Abdinur Abdullah. I'm a clinical pharmacist. And my question regarding to Professor Qureshi, the issue related with poor quality drugs. Was the issue isolated for manufacturing defect, or was it that the issue associated with poor handling of the drugs along the way from the manufacturers to the public health facility? Like, was the issue alerted? If at all it is poor storage, then the information can be shared back to the facilities, and if it is poor manufacturing defect, I think the authorities are around here, the PPP, that those drugs can be withdrawn from the shelves as soon as possible so that you refocus where you need the intervention. Thank you.
Okay, I've been told to start. So I think Dr. Fatma Sood, you started and said that many studies have been done, rightly so. So how is this going to be any different? So the studies on the use of the anti-shock garment, non-pneumatic, the balloon tamponade, they're all coming for refractory postpartum hemorrhage. So you've bled and you're going into shock, and you've done everything else. And part of the problem is that we've taken too long to treat it, is why we've reached there. So that is what we want to prevent. If we diagnose postpartum hemorrhage accurately earlier, we would not have reached there for many of those women. So that is what we are trying to deal with now, because it's the early, the accurate measurement of blood loss and the early detection, so that you then put in your interventions early. I think the other questions were, why did we exclude those areas, northeastern, which have a lot of postpartum hemorrhage related deaths? Now, we started this study when we were in the middle or in the thick of COVID. We did a lot of, like the first 1.5 years was when we could not even travel anywhere. So we did everything from the interviews to choosing the facilities through online interviews. We did approach several facilities in the northeastern region, but they would not fit into our criteria for one reason or another. The one that fitted almost there was Garissa, but through interventions that had previously been done by even UNICEF, Dr. Hadija, you are here, even their midwives were familiar with using the balloon tamponade. So they were doing a lot more than what we wanted to tell, so they were almost already using the bundle. So we could not include them. So it was more for logistic reasons. But we are very well aware that that map is from the west to the east and leaving out that whole area. Dr. Ogwell, you asked about what can we do with regards to, is it like the cost effectiveness? Yes?
Unit cost.
The unit cost. So this drape comes in from India, and it costs about, I think, $2 there. But the taxes, we have to pay a lot. But there is a paper, I can talk to you later. We have a publication that is being prepared at the cost effectiveness. And we are looking at cost effectiveness and cost cutting, both those things. So definitely if it comes to, we are looking at like if it comes to $1, if it comes to like 50 cents US or 20, what will it be? So we are in the process of preparing that. So definitely it will be cost effective. Dr. Khadija Abdallah, I think was for you. The quality of drugs. Is it the storage or is it the product? So yes, we know oxytocin is supposed to be controlled at from 2 to 8. It may or may not be happening, but when we talk to KEMSA, they say they supply it in refrigerated trucks to the county pharmacies. From there, it goes to the hospital pharmacies. They try their best. It may or may not be in the ideal conditions, but we really don't have a lot of control over that. The drugs that we were taking for analysis from all the 4 countries were sent to a university in Australia, Monash University, because we wanted uniformity in analysis. And there are 2 or 3 products of oxytocin and 1 of tranexamic acid. And when we talk to the healthcare workers in facilities randomly, they actually name the same drugs. When you're inducing labor, when you're augmenting labor, preventing postpartum hemorrhage, they will pick those because they are very poor quality. You end up using a lot more dosages and still you're not achieving. So we have been putting in that information into the pharmacy and board. Our study pharmacist for the trial was Professor Guantai, a very senior person at the university. She has done that. We have been engaging with the Pharmacy and Poisons Board for a very long time. We have the publications here if you wish to take a hard copy, but we have not had any movement in what will happen to those products. So we hope that with all this advocacy we are doing through our conferences like this, we will move there and hopefully then those products could be withdrawn. Thank you very much. I think those were all mine. I don't think I've left anything.
The last comment at take-home message.
The take-home message for me would be prevention, which means antenatal care. We take care of the diet so that we reduce anemia because we now have more evidence that anemia will definitely lead. And then stop harmful traditional practices because at the coastal region we have use of the massage, abdominal massage, which we know leads to postpartum hemorrhage. So message is prevention and then good quality product so we don't have a postpartum, and then for the hemorrhage, early detection. So there are several take-home messages from my research. Thank you.
Shukran.
All right. I'll take the next round, what I can recall. The so what question. Yeah. To me, it's that there are studies where you can just go and look at what were the key findings. All right? There are studies on health insurance. It says Muslims, are hesitant to take up NHIF because it's not Sharia compliant, and those who want, maybe they want takaful, so that is something that needs to be explored with takaful or it's easy. There's another study on adolescent sexual and reproductive health done, Dr. Nisa Bagazal. It looked at secondary school students in college in Mombasa, and you find like 60% are Muslim, but then when at the college level, they're only 30%, half enrollment. But then when you look at what was studied, it's like, would you take up STI screening? And then it's like the mothers were asked, as parents as well, would you mind if we did STI screening for your daughter? And so the parents say, only with my consent, and only if you share the findings. And yet when they did the STI screening, what did they find? They find that there are girls who say they're not sexually active, but they have STIs. 30% of those who said they're not sexually active have STIs. So those are things that, we need to look at. Then what are the interventions? Not necessarily involve Ganjoni clinic, but the findings are pertinent. There are studies like on traditional medicine. They looked at Marwaini, Rahma, Udu, looked at the effectiveness of Marwaini, the effectiveness of black seed haba soda. And there is some efficacy in treating malaria or treating respiratory infections. There we would need to involve the researcher as well. yeah, because maybe we need to do the trial that you talked about, because we saw the studies that have been done by Muslims on religion, health and religion. We didn't do trials. We just did mixed methods. So Dr. Khadija's question on hygiene. Yes, about northeastern province, poor uptake of hygiene. Why? Did we ask their perceptions? What do they think? Why are they not washing? Is it lack of water? Is it their perception that tayammum is promoted in Islam, so it's okay, it's not as important? So doing qualitative studies on that, I think for diarrhea or whatever, we don't engage the imams and preachers and madrasa teachers, right? Yeah, so for me, my call to Muslims would be, like we heard about ICU, somebody wants to have wudu as they die. But on admission, did we look, what's your religion? So that when you reach that stage, or before you reach that stage, we do have chaplains. You know, in the US, you find chaplains, all faiths are part and parcel of the hospital. But here, do we involve them right from the beginning and ask patients, you know, what spiritual support do you need? You know, that question. Is it too much work for you practitioners to add a question or two on that? To me, that would be the immediate first step, so that next year at this same conference, we can actually share our pilot of such a tool. Yeah? But otherwise, I shared my dream, the other things. KDHS is a valuable survey every 5 years. It collects data on religion. It collects data on ethnicity. But surprisingly, the last one, they just collected data, said 7% are Muslim, period. They left that variable buried. They just reported everything else by geography, age, sex, whatever. We can go and get those data sets and do analysis. They've done analysis for FGM and seen that there is declining trends for FGM. We can do for any other variables as Muslims. I think I'll stop there. I hope I've answered the key questions. Dr. Gwel, I hope.
Yes, yes. Thank you very much.
Thank you very much. Mine was just to comment on what would be the take-home message, especially for the children, especially in reducing mortalities. My suggestion would be we focus on health education, on preventive measures, and especially health promotion. I think most of the issues have been mentioned, especially children, issues to do with breastfeeding and vaccines and healthy eating and promoting just the health and well-being of our children. Thank you.
Okay, my take-home message is that IPC, that is infection prevention control, is everybody business. So let us emphasize on hand hygiene before and after we see our patients. And also, let's make sure that when we focus on our patients, let's avoid working on the patient's bed so that we avoid leaving most of the dirtiness on the patient beds. Let us be clean, especially on our working area. Thank you.
Okay, before Dr. Mahmoud tells us his take-home message, maybe just a question for him. You gave us a presentation on a very new practice in Mombasa and in Coast on intervention pulmonology. Are these services available in Mombasa? Maybe before you also give us your take-home message, inshallah. Jazakumullah khair.
Thank you very much, Dr. Faraj. These services are available in Mombasa. We have Olympus flexible bronchoscopy, and we also have a rigid bronchoscopy, and we have performed several cases. We also do the ultrasound-guided procedures, pigtail insertion, drainage, and even pleurodesis, and even pleural biopsies. So yes, and soon we are getting a medical thoracoscopy, and all these services are available in Mombasa. Take-home message, lung health is basically whatever you inhale. So smoking cessation is paramount, and reducing air pollution. Thank you very much.
Shukran, Jazakumullah khair. Thank you very much for our speaker. Just a round of applause. So some brief housekeeping announcements. It's time for tea break. It will be outside on the same building where we entered from, the main gate to the reception. It will be on the left side. Exhibition area also on the same side. Kindly let's be strict on time. We have our partners at the same place where the tea is served. The booths are there. Kindly also you are being advised to visit them. Outside the hall, there are posters being hung there. You can also have a look at them. So tea break is now. We are coming back after 15 minutes. So 11:15, inshallah.
Okay, let's please observe time. Okay, so for those who will want to use the washrooms, there are washrooms upstairs, but there are also washrooms